Good morning, good afternoon, and good evening to all our speakers, chairs, and the one bodies in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from the United Kingdom, Professor Angelos Kolias. Professor Kolias is a consultant neurosurgeon and clinical senior lecturer in Department of Clinical Neurosciences, Edinburgh Hospital and University of Cambridge, United Kingdom. He also holds an adjunct professor at the Humanitas University Milan, Italy, and in 2023 he was awarded a Hunterian professorship by the Royal College of Surgeons of England. His clinical interests include surgery for brain tumors, special interest is skull-based pituitary surgery, neurotrauma, cerebrovascular disorders, neuroendoscopy, spine surgery, and general neurosurgery. He is an internationally recognized for his research on traumatic brain injury and PET imaging for pituitary adenomas, with several publications in high-impact journals. He is immediate past chair of the Young Neurosurgeon Committee of the World Federation of Neurosurgical Societies, a member of the Global Neurosurgery Committee of the WFNS, and a member of Research Committee of the European Association of Neurosurgical Societies. He is also committed to advancing global neurosurgery and advocating for the provision of high-quality neurosurgical care to all those who need it. We are extremely honored to have him today at our webinars, and he will be talking about recently published high-impact article in NEJM, the Rescue ASDH trial. The speaker for the second session is our honored guest from Brazil, Professor Roberta Reder. Professor Reder is a consultant neurosurgeon at Hospital do Coração in Sao Paulo, Brazil. She did her specialization in minimally invasive neurosurgery from the Department of Pediatric Neurosurgery at the Johns Hopkins as well as the Boston Children's Hospital, Harvard Medical School. She is also a noted author with several publications in various peer journals. We are extremely honored to have her today at our webinars, and today she will be talking about her paper which won the prize at the CNS annual meeting in San Francisco as the Best Basic Science poster in the Pediatric Neurological Surgery section for the project titled Analysis of Medulloblastoma Subgroups in Pediatric Patients in Latin America. The chair for the first session of today is our distinguished faculty from Bogota, Colombia, Professor Andres Rubiano. Professor Rubiano is a professor of neurosciences and neurosurgery at the University of El Bosque, Bogota. He is the president of the Colombian Association of Neurosurgery as well as the president of Neurotraumatology and Intensive Care Chapter of the Latin American Federation of Neurosurgical Societies. He is the chair of the International Committee of Neurotrauma and Critical Care Section of the AANS and co-chair of Neurotraumatology Committee of the WFNS. He is also the principal editor of Neurosciences Journal, which is the official journal of the Colombian Neurosurgical Association. We are extremely grateful to him for accepting an invitation to chair the session of Professor Kolias. The chair for the second session of today is our honored guest from Israel, Professor Moni Benifla. Professor Benifla is the head of Pediatric Neurosurgery Department at the Rambam Healthcare Campus, Haifa, Israel, and was involved in the establishment of epilepsy centers there. He performs over 200 pediatric neurosurgery procedures annually. He teaches functional neuroanatomy and neurosurgery at the Technion Institute of Technology as well as other universities in Israel, and has received a number of awards for excellency in teaching. He is a member of several national and international scientific committees and is involved in the development of neurosurgical robots. He has published over 50 articles in various peer journals in the field of epilepsy surgery and pediatric neurosurgery. He is invited lecturer in Israel as well as around the world. Since 2017, he serves as the secretary of the Israel Neurosurgical Society. We are extremely grateful to him for accepting our invitation to chair the session of Professor Roberta Reder. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Professor Rubiano.
Thank you so much. Really welcome to the audience to this important session. As you mentioned, we are going to have the possibility to have the discussion of a very important process of research that has been developed by the and led by the group of Cambridge related to the acute subdural evaluation. And this was a very really way to study related to the importance of emergency surgery in TBI. And we have Professor Kolias, who is one of the main authors of the lead authors of the group, discussing this very important exercise in order to be described for the international community. We have recently the opportunity to be discussing for the original presentation of the paper at the AANS meeting, and definitely is something that is really well expected around the world, and it will be an important message in order to define practice in many regions of the world. You need to remember that acute subdural hematomas is one of the more lethal injuries. And before this study, we were discussing about the issues related to the initial management for performing the compressive craniectomy in these patients as a primary procedure. And also in other regions have been discussed the possibility to do a craniotomy versus the craniectomy. And we need to remember that this study was precise about that, about comparing the outcome of patients when we do craniectomy as a primary approach, and then compared it with a group that was managed with craniotomy. So I just want to welcome Professor Collias regarding this very important piece of work that has been published recently for the discussion around the world. So welcome, Andres.
Andres, thank you very much for the very kind introductions. Thanks very much as well to the ACNS leadership and of course Raza for hosting me and you know the wider team to present the study today. You can see the main authors group as well, but the PubMed yesterday, I think, updated now the full list of collaborators, and you can see that there are more than 200 names in the list of collaborators. I thought instead of going straight into the results of this study, that we should discuss a little bit about the background of decompressive craniectomy in traumatic brain injury. And I'm not going to spend too much time on this, but the process of opening the human skull, something we call trephination, there is evidence that this existed as a practice even up to 10,000 years before Christ. So there is archaeological evidence of this. And then Hippocrates was the first to describe skull fractures in a systematic way. And he also said that some of those should be treated with trephination. And then really the modern era of craniectomy, the way we think about it, so a wide sort of broad bone flap, an opening of the dura, started with a description by Theodore Kocher in 1901, who stated that if there is no CSF pressure but brain pressure exists, then relief must be achieved by opening the skull. And then we shouldn't forget that actually the first proper case series were published by Harvey Cushing in 1908. And he showed a significant reduction in mortality with the use of subtemporal decompressive craniectomy. So mortality went down from 50% to less than 15%. And I thought it would be interesting to show you here the original paper from Harvey Cushing. It was published in the Annals of Surgery in 1908. And this is his concluding paragraph, and he advocated for prompt exploration and decompression to avoid the complications of having edema in an unopened skull. And this very much is a nice summary of why we think that craniectomy, decompressed craniectomy, can be useful in certain cases. And then more and more people started performing craniectomy, but the process of craniectomy and the results were not sort of always very good. And, you know, there was a prolonged period that people were concerned about the potential of converting patients from dead to vegetative state. And you can see a paper published in 1968 in Journal of Neurosurgery. And again, this is very dramatic what the authors wrote, but they said the reason for reporting this experience is to warn others from doing similar surgery. And these concerns about craniectomy have persisted for a long time. Then in the 1990s, there was a resurgence of interest in the craniectomy itself. The reason was that ISP monitoring had become more established, neurological and neurosurgical intensive care had become more established, and we also had relatively improved access to imaging, so, you know, CT effectively. And this is a chapter written by Alan Roper, who is actually also one of the deputy editors of the New England Journal of Medicine, who was the main editor responsible for our papers. And he was calling for controlled trials with careful attention to inclusion criteria and the timing to determine if and how craniectomy should be used. Next, I think it will be useful also to think about the different types of cranectomy we have. So apart from describing it as bifrontal or a unilateral cranectomy, we also have the distinction between primary and secondary cranectomy. And primary cranectomy is typically a cranectomy when we leave the bone flap out following evacuation of a muscle lesion. This muscle lesion is usually an acute subdural, but can be other muscle lesions as well, but it's typically an acute subdural. On the other hand, secondary cranectomy is when we remove a large bone flap to control raised ICP. So this is a group of patients typically who have received medical treatment for brain edema or raised ICP. Some will have ICP monitoring. In resource limited settings, they won't have ICP monitoring, but they might be monitored and have some mannitol. And then eventually the decision is made to decompress them because of concerns about raised ICP or refractory brain edema. And if we look at the major randomized trials, multicenter trials of secondary and primary cranectomy, secondary cranectomy trials were published in 2011. That was a DECRA study, 155 patients. Rescue ASP was published in 2016, and that had 400 patients. And then Rescue ASDH is the most recently published study that I will talk about later on. I think at this stage, it's also useful to discuss why do we need RCTs. So there is a lot of talk, not just in neurosurgery, but also in other sort of circles, not just surgical specialties. I think, in medical specialties, they also have similar issues. But I think, we should think, why do we need RCTs? Because many people say, I know what is right. I don't need an RCT to tell me what's right. The issue is that when we compare treatments, let's say two different treatments, the two groups of people who receive the different treatments in the study should be as similar as possible, except for the treatment they receive. Okay, and that makes sense. Why does it make sense? Because it means that then any differences in the outcomes that you might find, mortality rate, rates of disability, they can only be explained by the treatment they received. If this doesn't exist, then that means that differences in outcomes that you might find could be explained by differences in some of the baseline characteristics. Some group might be younger, older, or have a better prognosis up front. And the nice thing with randomization is that the decision about which treatment each participant receives is made at random. And this is the best way so far. The scientists haven't come up with a better way. This is the best way to minimize selection bias. What is the issue with selection bias? The issue is that if a doctor chooses which treatment a patient should receive, then she or he might give the new treatment to patients who are sicker or to younger patients, or patients who have a better prognosis. And this could either exaggerate or hide any treatment effects. Okay, and I think this is something we should keep in mind. Obviously, randomized trials cannot be used for everything. So, for example, if you're interested in prognosis or the diagnostic utility of a specific diagnostic test, you don't really need a randomized trial. But when you want to compare two different treatments, they can be extremely useful. Coming back now to the secondary cranectomy trials, as we said, DECRA looked at early neuroprotective bifrontal cranectomy. So that was their hypothesis. They want to examine this type of bifrontal decompression. The Rescue ASP looked at decompressed cranectomy as a last tier therapy. So patients that have refractory raised ICP could be randomized to Rescue ASP. I think at this stage, we should also remind ourselves of the Glasgow outcome scale. So this is an 8-point scale that starts from death, then goes all the way up to good recovery. One of the issues that has sort of been discussed in the past is the lower severe and upper severe disability categories. And unfortunately, this is how it was described by Branzenet and his co-authors in 1981. Both of these categories, they have the name severe disability, but lower is very different to upper. With lower, patients typically would be dependent on others for all care. So these patients would be in a nursing home. They need help with everything, with washing, dressing, the sort of urination, with everything. With upper severe disability, patients can be independent at home. for at least 8 hours. That's by definition of the scale. And then you have the other degrees of disability, and then that gets better all the way up to upper good recovery, which is no injury-related problems. And if we look at the DRAC very briefly, just to remind everybody what the DRAC study showed, and that was a study of neuroprotective cranectomy for raised ICP. ICP had to be above 20 for at least 15 minutes in an hour. This could be cumulative 15 minutes, so not continuous 15 minutes. And what they found was that the mortality rate with cranectomy was exactly the same as with medical treatment, but then there was a higher rate of poor outcomes. So 70% at 6 months with surgical treatment versus 51%. And the reason we think is that obviously those patients, they didn't need a cranectomy. They were just managed with this sort of concept of neuroprotective cranectomy. So they were exposed to all the risks of a cranectomy. We are all aware of the complications, but they couldn't derive any benefits because their ICP wasn't significantly raised. I'll briefly mention the rescue ICP results, and this study was published, as I said, in 2016. If anybody wants to access the paper with your QR code, you can go straight to the paper. And this study was organized in 3 stages. Stage 1, the usual simple treatments. Stage 2, then we could add ventriculostomy, inotropes, mantle or hypertonic saline. And then if the ICP remained above 25 for at least an hour, patients were randomized to cranectomy or medical treatment with barbiturates. And this is one of the nice things that a randomized trial allows you to do, that the groups are well balanced. So the 2 groups, surgical and medical, were well balanced in terms of their other treatments that the patients received. So you can see craniotomy for evacuation of hematoma, ventriculostomy, osmotherapy, so very similar numbers. And then after randomization, most of the patients in the surgical group had a cranectomy. Some didn't, either because so some patients, for example, went to the operating theater. One of them had a massive epistaxis and didn't have a cranectomy. But if you look also in the medical group, about 37% of the patients did have a cranectomy, and this was allowed by the protocol because their ICP had become refractory. Despite barbiturates, the clinicians had no other treatment to provide, so this was allowed by the protocol. And when we looked at the results at 6 months, and this was a sensitivity analysis, but I think it's useful because it allowed us to collapse the GOSC in 3 categories. So dead, the red is the dependent patients, so vegetative state or lower severe disability. And then in green, you have everything else. So these are patients who are at least independent at home or better. And you can see that there is clearly a significant reduction in mortality with surgical treatments, so 22 percentage points. But a lot of that became patients who were dependent at 6 months. Some of that also translated to the better outcomes, but it wasn't statistically significant at 6 months. However, the surgical patients continued improving at a faster rate, and you can see that the p-value was significant at 12 months. Now, the cranectomy also had significant effects in terms of the ICP, and all of those indices were significant, and that's something that is well described. And then last year, we also published the 24-month outcome data in JAMA Neurology, and again, you can access the paper online if you want. But this was quite useful as well because we demonstrated beyond any doubt that the surgical patients continued improving up to 24 months. So you can see the sort of good outcomes. The good outcomes are coming up to that line there. So everything from that line to the right is a good outcomes. And you can see that that continued increasing from 6 to 12 and then also up to 24. And when we did the statistical analysis, we did confirm in the pair time point comparisons that between 6 and 24 months, there was an improvement in the surgical group only. And then when we looked at the net change of the Glasgow outcome scale over 24 months, we found that 30% of the surgical group patients improved by at least 1 grade. There was some improvement in the medical group only, but it was only half of the surgical patients, half compared to the surgical group patients. So patients in the surgical group were more likely to improve over time. Another way of looking at the outcomes of the rescue SP was to look at the outcome of the extra survivors at 24 months. And what we could say is that for every 100 patients treated with surgery rather than medical intent, you end up with 21 more survivors. About 30% of those would be dependent, but that means that 70% would be at least independent at home or better. I think that is useful for family discussions. As we said, DECRA and Rescue SP had some differences. One of the main differences was that the ISP threshold was very different and quite low for DECRA. This was because they had a hypothesis that craniotomy could be neuroprotective. It wasn't. So patients were randomized in tier 2, whereas in Rescue SP patients were randomized in stage 3. And that explained the differences in mortalities. Moving on to the current study, if that's okay. So the Rescue ASDH trial was targeting patients who had significant trauma, needing evacuation of an acute subdural with a large trauma bone flap. And the question was whether craniotomy could lead to better functional outcomes. I'll briefly describe the path to the Rescue ASDH trial. So this was the Cambridge series. This was a retrospective series, single center, 5-year period. And we had 91 acute subdural patients. 51 of those were treated with a craniotomy, 40 had a craniotomy. The decision about the treatment was made by the treating neurosurgeons, and therefore it's not a surprise that patients who had a craniotomy were younger, had a worse pre-op Glasgow coma scale, and a worse looking CT scan. The way to adjust for this difference in the baseline characteristics was to come up with a standardized morbidity ratio. So what we did, we adjusted the Glasgow outcome scale at 6 months for the crash outcome prediction. So this is a nice way of adjusting. And you can see that here, even though there was no statistically significant difference, the standardized morbidity ratio of craniotomy was a little bit lower compared to craniotomy. So we thought that that a randomized trial would be justified on the basis of this, to try and find out what exactly is going on. And I think it's worth remembering this. Then we did a survey of the UK Neurosurgical Society, and we had responses from the vast majority of the UK neurosurgical units. And what was interesting was that the vast majority of the respondents said that they didn't think that there was consensus within their department about the surgical technique, craniotomy or craniectomy, employed for treating patients with acute subdural. So you can see that almost 6 out of 10 said that they didn't think that there was consensus. And our assumption was that the lack of consensus is probably because of the lack of high quality evidence. Then we looked at the current database. So this is a large trauma registry in the UK. It's purely observational, simply collecting data. And we examined 2,500 patients who had an acute subdural, traumatic acute subdural, who had a craniotomy or craniectomy. We couldn't distinguish what type of surgery they had, but we knew that they had evacuation of an acute subdural within 48 hours from injury. What we interestingly found was that the time interval from injury to craniotomy was not related to survival, which is interesting in its own right, and that's probably a discussion for a different day. And we also found that the direct admission to a neurosurgical unit, as opposed to transfer from a smaller hospital, again, wasn't associated with mortality. On the other hand, all the known prognostic factors like the age, pupils, injury severity score, Glasgow coma scale, all of those were strongly related to mortality. So we used this pre-trial work to inform the methodology and the design of the Rescue ASDH trial. Because we knew that there were strong opinions and a lack of consensus, we decided to have intraoperative randomization after evacuating the clot to try and replicate actual clinical practice and also to minimize bias. We adjusted the Glasgow outcome scale for age, GCS, and pupils because we demonstrated that it was associated with survival. And then as we So that the time to craniotomy and direct admission to a neurosurgical unit were not associated with survival. We did not have any inclusion-exclusion criteria based on those two parameters. And I think it's nice to try and justify any decisions that you make when you are designing a big study like this on the basis of proper evidence. So the study was funded by the National Institute for Health Research in the UK with a grant. And in terms of the methods, the patients were randomly assigned, as said, to craniotomy or craniectomy. The sample size was 440, and that was for a number needed to treat of 7. In other words, the study had a 90% power to detect a difference between the groups of 14 percentage points. That is an absolute difference with an ordinal analysis, or 80% power with a binary analysis. So binary meaning good versus bad outcome. And the primary outcome was the extended Glasgow outcome scale of 12 months. We had a number of secondary outcomes, including complications, adverse events, and then also quality of life. In terms of the inclusion criteria, we included patients who were adults above the age of 16 with an acute subdural hematoma on CT. And the main inclusion criterion was that the admitting neurosurgeon felt that the hematoma needed evacuation with a large bone flap. So that was a large trauma bone flap, a question mark skin incision. And we had said size EG, for example, size at least 11 centimeters. And we had also allowed the inclusion of patients with additional lesions, such as ICH or contusions. We had some standard exclusion criteria, so bilateral acute subdurals, previous enrollment in the study. So, as I said, patients were taken to the operating theatre. The skin flap was reflected, the bone flap was elevated, and then the hematoma was evacuated. And after the hematoma had been evacuated, the operating surgeon would make a decision about whether to randomize the patient or whether the bone flap had to be left out. Because as we know, if there was significant swelling that would preclude a replacement of the bone flap without pressure on the brain, then the bone flap had to be left out. And all of those patients were followed up in the observational study. The rest of the patients were randomized, and we had the process of online and telephone randomization. We were randomized to craniotomy, where the bone flap was replaced, or craniectomy, and the bone flap was left out. With left out, we mean that it could be stored in the abdomen as well if desired. And we had 462 patients eventually randomized from 40 centers in 11 countries. And you can see the world map there. We had contributions from the UK, India, Canada, Malaysia, Germany, Spain, the US, Australia, Hungary, Pakistan, and Singapore. This is the flowchart from the paper. Most of the patients who were not enrolled were excluded because they didn't have acute subdural. You can see a large number there who were screened or were below the age of 16 or had bilateral subdural or other miscellaneous reasons. And then we had 462 who were randomized, 407 who were followed up in the observational study. And this data will be published separately. Then 12 were excluded because of lack of valid informed consent. So in the end, we end up with 228 in the craniotomy, 222 in the craniectomy. You can see that some of those who were randomized to craniotomy had actually decompressed craniectomy at the time of the randomization. And this was because sometimes, the brain did swell up between the decision to randomize and until the randomization outcome came back. And also some patients in the craniectomy group ended up having a craniotomy. So the bone flap was replaced simply because, some patients then, some surgeons made the decision to actually leave the bone flap in. Sometimes a senior walked in and said, put the bone back in. But these numbers weren't big, and we also followed the intention to treat analysis, which is the valid method of analyzing, but we did have a per protocol analysis. At 12 months, you can see that we had 215 who had an outcome in the craniotomy group, 211 in the craniectomy. So these were very good follow-up rates. In terms of the characteristics at baseline, and this is, as I said before, the nice thing about randomization, you end up with very well matched groups. So the mean age was 48 in both groups. Majority were male. In terms of race and ethnicity, very similar numbers. About 14% to 15% in both groups were on a blood thinning medication. About 40% had extracranial injuries, and about 65% in both groups had a GCS below 9. Also very well matched in terms of the CT findings. So 86% had midline cyst more than 5 millimeters, etc. So very, very similar. In terms of the surgical details, you can see that most patients in both groups had a question mark incision. A drain was used in most of the cases. The length of the bone flap was similar in both groups, about 13 centimeter in AP diameter. Location of the subdural was slightly different, so 44% of the craniotomy had it over the left hemisphere, as opposed to 54% in the craniotomy group. So you might find differences like this unless you have a study, randomized study, which is sort of in the thousands of patients. In terms of other hematoma evacuated, you can see that about 20% in both groups had an additional hematoma evacuated. And then in terms of ISP monitoring, you can see that this was not universally used. So about half the patients did not have ISP monitoring post-op. And this was a pragmatic study that took place in resource-limited settings too. Moving on to the main results. So the primary outcome, as you can see here, in terms of the odds ratio of the ordinal outcome, there is no difference. Okay, so the odds ratio is 0.85, and it is crossing 1. So there is no statistically significant difference between the two groups. However, if you look more carefully, and I think this is why it's nice to look at the graphs here, and this is the results at 12 months. On the top, you have the craniotomy group at the top, craniotomy at the bottom, and you can see that most of the outcomes, especially the better outcome categories, so upper good, lower good, moderate disability, they seem to be slightly more in the craniotomy group. At 6 months, again, a very similar picture. The only difference is that the mortality rate was lower at 6 months in the craniotomy group, but more patients were in vegetative state at 6 months. And then those patients, I think what happened is that they died, and that's why the mortality rate at 12 months in craniotomy was slightly increased. But I say these are not statistically significant differences, but there is a clear trend, at least the way I'm looking at the data. In terms of the quality of life, we have craniotomy there, craniotomy on the right. And again, there is possibly a trend towards higher quality of life scores in the craniotomy group, but this wasn't statistically significant. In terms of ICU length of stay, you can see that it was very similar, about 13 days in both groups, no differences there. And then in terms of the therapy intensity level, so this is a scale that looks at the intensity of therapies to control raised ICP or brain edema. Till 0 is when there is no specific ICP direct therapy. Till 4 is hypocapnia, hypothermia, metabolic suppression. And again, it was very, very similar rates of the various stages of TIL between the two arms, between the two groups. In terms of the surgical endpoints, and I think this is very useful in terms of coming up with some recommendations about what this study means for our day-to-day clinical practice. You can see that 14.6% of the craniotomy group, so about 15% versus 7% of the craniotomy group, had an additional operation in their head within the first 2 weeks after randomization. And when we look at this data more carefully, about 9% of the craniotomy group patients had to have their bone flap left out after an initial craniotomy. That was not at the time of the initial operation, that was later on. So it's about 10%. However, this is probably balanced out by the significantly higher rate of wound complications, including surgical site infections, in the craniotomy group. So about 12% versus 4% in craniotomy. We also looked at the number of pre-specified subgroup analyses, and those subgroup analyses again didn't show any significant difference. So when you look at the so this is a forest plot, and on the left hand side you have a result that would favor craniotomy. On the right hand side it would favor craniectomy. So when we look at the various age groups, there isn't any significant difference. When you look at UK versus non-UK, again, there is perhaps a trend in the UK only, but I wouldn't say that this is significant. Again, another trend there towards perhaps some better outcomes in LMICs with craniectomy. But the issue is that if you do 100 subgroup comparisons, you're bound to find something simply by chance. Okay, so we need to be very careful with this subgroup analysis, especially when there are several of those. And then in terms of the Glasgow coma score presentation, again, didn't seem to make a difference. We also did a per protocol analysis. So those patients that at the time of the randomization did not adhere to the randomized allocation, they were excluded. But this obviously biased analysis, as you can imagine. And again, you can see that this is not statistically significant difference there, but perhaps a trend. But I say this is definitely a biased analysis. So to wrap this up, and we can discuss the limitations, I think, during Prof. Rubiano's critique of the paper. I think as a summary of the work that we have done so far, and also the work of the DRAC investigators, I think we can say with relatively high levels of confidence that an early bifrontal craniectomy for diffuse TBI with moderate or mild raised ICP isn't useful. So this is what the DRAC showed. A last tier craniectomy, we think that it is a life-saving intervention for refractory raised ICP. So when used as the last tier, as a last resort following TBI, this was what the rescue ICP showed. We now have evidence that craniectomy patients continue improving beyond 6 months, and at 24 months, 45% of those were at least independent at home versus 31% in the medical group. So there is an improvement in terms of the independence as well compared to the medical group. In terms of the primary craniectomy study, the rescue ASDH results suggest no difference between craniotomy and primary craniectomy. So our thinking is that the practical implication of this finding is that the bone flap should be replaced unless this would lead to compression of the brain. I think all this debate about craniotomy brings up issues around value and also ethics. My thinking and also the way I practice is that unless a prognosis is bleak, and this will be somebody with brainstem injuries visible on CT, bilateral fixed dilated pupils, I would consider a secondary craniectomy for patients who have refractory raised ICP. I think discussion with family is key. And I think the other issue is that only living patients have the potential to convalesce and rehabilitate. I think we should remember this. Lots of people thank, mainly my mentor, Professor Hudson, who is also the CEI of these studies, and also John Pickard, who was the previous head of the department, and also the rest of my colleagues in Cambridge, also my colleagues from the Global Neurotrauma Group, particularly Professor Indira Devi from Bangalore, Bangalore was the top recruiting site, Nimhan's top recruiting site in this study, and also the rest of the collaborators, including Tony Figazzi and Andres Rubiano, and also all the collaborators on all our studies, and of course the patients and their relatives. So I think that's everything from me.
So thank you so much, Angels. I think this is a very important description, very well detailed, of the technical aspects of the study and how the results can have these implications for the interpretation as you mentioned, these findings can change practice of at least improve the information available for building protocols worldwide. So I will be sharing here slides regarding the impact of the study. And again, thank you, Dr. Raya and the Congress of Neurological Neurosurgeons in order to allow us to discuss these very important topics, understanding that trauma is one of the most critical disease in the global burden of disease study, and how it affects population, especially young population that regularly drives all the economical issues in many regions of the world. So I will want to show briefly. Okay. So having the opportunity to read the study from first hand, and also being in the process of investigating this condition, I think we all understand that when we perform a cranial decompression as a primary intervention for patients with TBI and mass lesion, as Angelos mentioned, there are a lot of discussions, and because of that, with the same group of the Global Health Research Group in Neurotrauma from Cambridge, there was initiatives in order to fill these gaps in the knowledge. And especially one of those was the consensus for cranial decompression that was posted in Cambridge some years ago. We published some papers related to the analysis of the current status of decompressive craniotomy before these studies, and we performed very specific reviews supported by the Brain Trauma Foundation in order to develop specific questions for the Brain Trauma Foundation guidelines. We published in 2020 the update of the decompressive craniectomy recommendations, focus on the two studies that Angelos discussed at the beginning, the rescue ICT, and also the DRAC study. So from these studies, we know that the role of primary decompression, especially when evacuating an acute subdural, cannot be extrapolated with the previous evidence to primary disease because of this study was not finished at that time. So after we performed the consensus, that was very significant because it was one of the first consensus that really bring the expertise from many people performing this procedure as a primary procedure in LMICs. There was some interesting recommendations coming from the consensus. I just want to mention that briefly. The third one was after evacuating an acute subdural hematoma, if the brain is bulging beyond the inner table of the skull intraoperatively, we can consider leaving the bone flap out based upon clinical and radiographic findings. There was a 100% agreement in that recommendation. After evacuating an acute subdural hematoma, if the brain is very relaxed and the preoperative computed tomography imaging is not keeping with a high risk of progressive brain swelling, the bone flap should be replaced. Especially there was one condition that was mentioned in elderly patients or mechanism of low energy. The agreement was 87%. For the intermediate category of acute subdural hematoma patients, brain neither very relaxed nor bulging, surgeon judgment will be used to decide whether to leave the bone flap out or not. And the agreement in this recommendation was 97.9%. So it's interesting to see after the discussion of the study how many of these recommendations previous of the process of the evaluation of the intervention were really attached to the actual practice and to the findings of the study. So Just to mention briefly for the technical aspects, I think also one of the very important aspects of this study was the inclusion of centers from different contexts. Angelos mentioned about the Niemann Institute in India that bring many of the patients of the study. So we understand that from the perspective of high-income settings and LMICs, the regular use of both techniques is quite common, but sometimes there are different materials in order to perform, especially the cranioplasty. But the inclusion of these two contexts and environment decrease the possibility of bias due to the lack of experience of the surgeon performing the surgery for selecting patients for one or other procedure. So definitely, as the experience of the surgeon was very important in taking the decision of defining one procedure or the other one, that was one key aspect. The block randomization process and stratification according to the geographic region, age group, severity of injury, and CT findings, it can generate an internal valid study that will produce reliable evidence about the impact of both techniques for different group of patients. The outcome analysis was performed centrally blinded to the trial group assignments, decreasing the bias, and with the modified intention to treat the ordinal analysis, decreasing the impacts of the patients that were moved from craniotomy to craniectomy, and the patient moving from craniectomy to craniotomy, despite being assigned to different groups. And there are also other standardizations, like the standardization of the minimal size of the bone flap for both techniques. So that's a really important aspect, taking into consideration how to minimize bias in this type of analysis. As was also by Angelos and also discussed, because all these post-hoc analyses for more than 12 months and even 24 months are really important in order to see the trend for recovery of the patient. So the evaluation of the additional 12 secondary outcomes for each group, including also the therapy intensity level scale, discharge destinations, adverse effects, surgical complications, readmission for cranioplasty, hydrocephalus requiring shunt. The study really reports no difference between many of these secondary outcomes for both groups. And that's a key aspect for understanding the impact of the results of the primary outcome. Also, we need to mention that as the methodology has been based on the surgeon discretion opinion for the surgical techniques, including the main intervention, also including the skin incision types, we know that for the craniectomy group, there was a lot of complications compared with the craniotomy group, especially for infection and operative site complications. So leaving the skin incision type at the surgeon discretion, and also the possibility of evacuation of intracerebral hemorrhage, perform cisternal drainage, now that we are discussing this specific intervention in many regions of the world, the dural closure method in the craniectomy group, and the use of wound drains. All these interventions that affect the complications of the surgical site would left at the discretion of the surgeon. So this can, integrate some minimal aspects of the technical that could be discussed. So also they have the possibility of create some selection bias because there is uncertainty for the surgeon and the patient of which treatment is the best. Concerns that one intervention is too risky for some subjects can be a valid reason for specifying that subjects with certain characteristics can receive a given intervention rather than really randomizing them. But this can generate also some specific type of bias. There is channeling bias and also the susceptibility bias. So variations in the technique, including skin incisions, evacuation, dural closure, or the use of wound drains, can have some influence over some of the outcomes that were used to. So definitely, the important aspects are that the findings of this study might not be relevant for resource-constrained environment or military settings, where sometimes prophylactic cranial decompression is regularly used due to the absence of limited opportunities for advanced ICU postoperative care. In this study, all patients receive standard postoperative ICU care according to each center protocols. So now that we are here in a very big international audience, this is a key aspect that we need to understand. The study brings light into the decision-making point for emergency neurosurgery, considering the importance of having this balance between reintervention requirements or the surgical site-associated complications. So we definitely, in terms of patient safety, need to consider the possibility of replacing the bone bag, but always considering that maybe some reinterventions will be required. And this open a very important door in order to think about how to select better these patients, how to follow better these patients. I think personally that what we need to do now after the results of this study is really understand which patients need to be taken to a decompression procedure, not only based on the imaging and not only based on the clinical aspect, but also definitely heavily based on advanced neuromonitoring, integrating non-invasive and invasive systems according to the resources. This is a point that we have been advancing and discussing. We recently published an article related to these aspects in something that we call the cranial compartment syndrome, and looking for the importance of really heavily based the decisions of selecting these patients on advanced monitoring, either, as I mentioned, invasive or non-invasive methods, for really understand which patients need to be taken to decompression. Because we understand that once we take these patients to decompression with the bone out, there are important associated complications that relates not only in the technique per se, but also in the postoperative care management, the experience of the group, the resources, that is something related to the context where the patient was taken. So this, at the end, is a great example of understanding what were the recommendations of the consensus of reconciling clinical experience with the clinical evidence. A few times you see how this consensus can match previously to the final result of the clinical studies, the results. And this is a very perfect match of how the expert teams and how the experience was integrated and definitely followed the science of proving a specific result of this intervention. So I definitely think that we need to congratulate the group of Professor Hutchinson, of Dr. Angeles, for generating this important study that definitely will be adding more evidence to the neurotrauma care science. So I don't know, Dr. Raja, if there are going to be some questions taken from the audience, but definitely I think this is a very important topic that will generate even change in some of the recommendations at international level.
Thank you, Professor Angeles Colias and Professor Rubiana, for this wonderful description of this landmark study. And we'll just run through the questions, if any. Well, we have Professor Indira Devi with us, who is one of the lead contributors of this study. Professor Indira Devi, would you like to comment?
Yeah, I have no comments. I think all have been adequately covered.
Thank you very much.
Both by Dr. Angelos and Rubiano.
Thank you very much for joining me. One question to Professor Colias is that I may have missed it in between, but what was the incidence of hydrocephalus in the DC group as well as in the craniotomy group? In the DRAC it was 10, and it was regarded as one of the factors for poor outcome that leads to axonal stretching. So how did this entity affect the outcome in your trial?
Thank you. That's a good question. So all of the data is in the appendix rather than the main paper. That's why you may not have seen it. But essentially, 6 patients in the craniotomy group had a shunt by 12 months, as opposed to 8 in the craniotomy group.
There was not much of statistical difference.
No, and
Okay.
pretty low. Yeah.
Thank you very much. Liu, any questions from you, Liu?
Yes, Prof. I have 3 questions, Prof. Sorry. First, usually in my practice, we look at the degree of midline shift compared to the thickness of subdural. If we found that the midline shift more than the thickness of subdural, indicating there is a edema, so would that be taken into account in this study? My second question, Professor, in terms of quality of life, do you assess the quality of life both with decompressive craniotomy after the cranioplasty, because sinking flap syndrome does cause lower quality of life? My last question, Professor, you allow crossover about more than 10% from craniotomy site to a craniectomy site, where you're looking at a significant of 5%. Would that affect the overall result of your study? Thank you, Professor.
Yes, thank you very much. These are good questions. So in terms of the cranioplasty, about 100, so, just looking at the appendix again now, by 12 months, we know that 113 patients of the craniectomy group had a cranioplasty. So, that's clearly not all of them. If you take into account that some of them were dead, that would probably be around 2/3. So, that is a good point. But the result is the result, and the result shows that there is no difference in outcomes. But in my view, I think there is a small trend towards better outcomes, and that of course might play a role. But the outcome is the outcome, regardless of what else might explain it. So I don't think that this would change the practical recommendation, if that makes sense. And we all know the complications of cranioplasty. Cranioplasty is not a benign procedure anyway. You also mentioned about the midline shift against the width of the subdural, and I think that is a very useful sign. I use this sign as well. This sign wasn't used as one of the inclusion or exclusion criteria, if this is what you're asking. So again, I think that is a useful sign, but I would still try and put the bone flap back if I can, regardless of that sign, on the basis of what we discussed. And as long as you're accepting that about 10% of those bone flaps will have to probably come out a little bit later on. The other issue, and I think this is something that Andres mentioned as well, I think it depends a little bit on your setting. So if you work in a remote setting and there's only 2 neurosurgeons, the facilities aren't great in terms of monitoring out of hours, you might err a little bit more on the side of the caution and leave the bone out, simply because you don't want the patient to sort of herniate in the middle of the night, right? So I think a lot of these decisions depend on the setting that we practice. But in my setting, and this is what I've been doing since the results were published, I'm trying to put on the bone flaps back if I can, unless the brain is bulging. The third question that you had was about the crossover rate and whether this might have affect the results. I showed you the per protocol analysis as well, with all those patients excluded, and you saw that the direction of the treatment effect, so the odds ratio was very similar. It wasn't different to the intention to treat analysis. So I don't think that this has affected the results.
Yeah.
Okay.
Yeah.
It's very, very similar.
Yeah, Professor, just want to bring up that in the craniotomy side, eventually, if the surgeon violates the protocol, converted into craniectomy, I will presume that those cases will have a poorer prognosis, more brain swelling. So
exactly.
By protocol, actually, you remove those with poor prognosis out from the craniotomy side. That amount is more than 10% of the total patient, and you are looking for differences of only 5%. So would that make a lot of difference to the study result, Professor? Yeah,
I mean, we also removed the patients from. We also did the different things. So, the reverse. The craniectomy group, quite a few had their bone flap put back in, even though they were randomized to craniectomy. The bone flap was replaced. Yeah, and so those were also removed from the per protocol analysis. Yeah, but for the decompressive craniotomy side, if they put back the bone, I presume usually those without brain swelling, they have a better prognosis. So you're actually removing those with better prognosis out of the craniectomy side. Actually, the effect will be double. It may cause not real differences, which I think, Professor. I fully agree, and that's why I said that the per protocol analysis is a biased analysis. The only reason we put it in is because the reviewers insisted on it. I don't pay any attention to a biased analysis. So the best method is, because these discussions can go on forever. That's why we use the intention to treat analysis, and this also reflects real world practice. So some of the issues that Andres raised, there are valid issues as well. The issue around what is the best skin incision, use of drains, use of ice monitoring. These are all valid issues. But you cannot randomize every decision. This study would never finish, and you have to make a decision at some point. What is the critical question that I want to answer? And with this study, we want to answer the question about what to do with the bone flap, and we didn't want to exert too much control over all other parameters, because then you end up with a study which is very artificial. So there is this concept for the last decade or so of pragmatic randomized trial. So you want to see a randomized trial that and how it works in the real world, not in a very artificial environment. So I think this is a real world result.
Yeah. May I add one more question, Professor? Because Prof. Andres did shows that if the brain swelling happen, it's 100% agreed that a bone flap should be removed in the consensus statement. So would you think that in the future, such study you can perform those without brain swelling? Those without brain swelling, and you randomize remove bone or prophylaxisly or not removing bone, would that better to reflect the result of the study? Because there's 100% agreed with the consensus statement that if there's a brain swelling intraoperatively, there we remove the bone. There's no argument about it, Professor.
Correct. Yeah. So you're talking about when the brain is bulging outside the sort of inner table. I mean, I don't know how you would put the bone back in those cases. Some people would leave it hinged, I think, and that might be an option. So I think for those cases, an option of hinged craniotomy potentially. And I know that Professor Indira Devi has an interest in this. That might be an option, but to put the bone back and fix it with plates and screws, you wouldn't be able to do that, because you'd have to compress the brain, and I think nobody in their right mind would do that. So I wouldn't do such a randomized study. But I think the hinged craniotomy study for that subgroup of patients that have brain bulging intraoperatively, I think that would be a worthwhile study.
Yeah, what I mean is, in the future study, will you remove those group with brain swelling intraoperatively from your randomization, and you only include those without brain swelling intraoperatively to better reflect the negative effect of taking out the bone, Professor?
Oh, you mean from the analysis?
Yes.
No, I wouldn't. I wouldn't remove any patients from the analysis that have been randomized in the study, because you end up with a biased group.
How about in the future study, Professor? In the future study, if you're going to have similar study, but you remove those with a brain swelling from randomization?
Oh, you mean that you don't even randomize them?
Yeah, you remove them from the study. You only randomize intraoperatively. Those without brain swelling, you will randomize with replacement of bone or removal of bone. That would better reflect the complication of removing the bone during such surgery, Professor?
But, I mean, this is what we did. The randomization was intraoperative, and we had specified that if the brain is bulging and you cannot put the bone back in case of randomization to the craniotomy group, then don't randomize the patient. So this is what we did in the study. I don't know what you mean.
These discussions can go on for infinity, I think. We should wind up. We'll ask Professor Rubiano for his concluding remarks.
Yeah.
I just want to add that definitely here there is two important things from this brief discussion that we just have is that the Zunkeler index has been proposed in many regions as one of the important topics that taken into account for selecting patients. So it's the Dr. Leo mentioned about that Zunkeler index. So and the other aspect is that as Angelos mentioned, the hinge craniotomy study will be a next important step into the analysis of these patients, because definitely if we have a new technique that it will decrease the possibility of reinterventions and complications of the wound and things like that, that will be something really helpful. So we need to take into account many of these aspects of these technical discussions in order to understand better what is happening with this patient. And as I mentioned, also the possibility to really to brain physiology, understanding aspect like the perfusion in that bulging brain and also the compression of the structures and things like that we can evidence through other monitoring techniques can allow us to select better which patients are going to be in each one of the arms.
May I just go back to this point?
Sure.
Because I may not have answered the question properly, but I think this is what you're referring to, Dr. Liu. And, you know, this is the intraoperative randomization. So we said this is from the study. So we said randomized after evacuating the hematoma, except if there is significant swelling that prevents safe replacement of the bone flap. So I think this is what you're proposing, but this is what we did, unless you're proposing something different.
Right, that's well understood. Well, thank you very much. We had a lively discussion and a wonderful lecture from Professor Collias and wonderful comments from Professor Rubiano. And we'll move on to the second session. And Dr. Liu would be taking over this session. Please, over to you. Thank you very much.
Thank you. So now we move on to the second lecture. Thank you to both Professor Angelos and Professor Andres. We move to second lecture. May I call upon Professor Moni to introduce our second speaker, Professor?
First of all, I would like to congratulate the previous team for this important work. Unfortunately, in neurosurgery, we are lack of evidence-based medicine, and all these trials give us some tools in order to know what to do during our daily routine. Unfortunately, as a pediatric neurosurgeon, we have no evidence-based medicine, and we have to rely upon the adults literature. There are some questions that I have also to ask the trauma team, but this is for another day. So moving from the acute illness to the chronic illness, we will speak today about the subgroups of medulloblastoma. Medulloblastoma is the most common pediatric solid tumor, and already 100 years ago, Cushing found that complete resection is probably the most important positive prognostic factor. Yet the prognosis was bad, and afterwards we started to give radiotherapy and then chemotherapy, and currently we rely upon the studies of Roger Packer and Wissoff from early 90s that we know that for medulloblastoma, the treatment is complete resection, gross total resection, chemotherapy, and neuroaxis radiotherapy. The problem with the treatment is there are some significant side effects, both for the adjuvant treatment and for the surgery itself. We know that about 25% of children will have a mutism, cerebellar mutism, which is a significant morbidity with these procedures. We know that these patients in the long run don't really have good quality of life. We see that on our daily basis, patients that I operated upon 15 years ago that did remarkably, and they are now alive, but very, very low quality of life with regards to independence of work, marriage, etc. During the 2000, the first decade of the millennium and the second decade, there were many studies that were made to try and subgroup the medulloblastomas. And eventually there was a consensus published in 2012 that divided the subgroups to 4 subgroups. And actually we saw that there is a different prognosis, depends on the molecular subgroups. For example, for WNT, excellent prognosis, and for type C or type 3, it's a very poor prognosis, etc., etc. And the question is raised, whether should we change the treatment of these patients instead of this aggressive treatment, gross total resection, chemotherapy, and radiotherapy, according to the subgroups, which may reduce the morbidity of these children. The other question that we ask ourselves, according to different papers that were published, that we found that in different countries or different ethnicities or in different For example, in low and medium income countries, there may be different prognosis for children with the different types of the subgroups. Although in these low-income countries, the change in treatment will be a reflection of the economical status of this country. So now, today, we have Dr. Roberta Heder from Brazil, who is a pediatric neurosurgeon. She did a research fellowship in Boston Children's Hospital, Harvard Medical School, and Johns Hopkins Hospital under supervision of Dr. Alan R. Cohen, who is one of the fathers of pediatric neurosurgery. And she did her neurosurgical training under the supervision of Professor Louis Borba. Dr. Heder, please.
Thank you very much for the nice introduction. Let me just share my screen. So again, I'll be talking about the analysis of medulloblastoma subgroups in pediatric patients in Latin America. First of all, I'd like to thank for the opportunity of being here and giving this talk. And also I'd like to give a thank to Professor Borba for all the training, and Dr. Sidney Appleman. He's one of the responsible for the pediatric oncology team at the Santa Marcelina Hospital where I work at. I have no disclosure. So just a little bit of introduction of medulloblastoma before we talk about the Brazilian protocol treatment. Medulloblastoma, as everybody knows, is one of the most malignant brain tumor in children. And therapy consists of basically surgery, craniospinal radiation, and chemotherapy. Although of the multimodal therapy implemented, 30% of patients will succumb to the disease and also will have long-term side effects of treatment. A little about history. Harvey Cushing and Percival Bailey, they worked together at the Peter Bent Brigham Hospital in Boston between 1919 and 1928, and they set the basis for medulloblastoma for what we know today. Bailey was a neuropathologist and also a neurosurgeon. Both of them described the mitosis, this mount round nuclei of the cells, the tendency to arise from the cerebellar vermis, and the tendency to have leptomeningeal metastasis at diagnosis. So they set the foundational work for the clinical characteristics, operative techniques, and histopathology of medulloblastomas for what we know today. So medulloblastoma consists of approximately 20% of childhood brain tumor. There is an incidence about 5 cases per million children. About 70% of the kids with medulloblastomas are under the age of 10. And that has a great reflection on the therapy, because we know that under the age of 3, it's really hard to implement radiotherapy. There's a peak incidence between 1 and 4 and 5 and 9 years. Although rare in adults, medulloblastoma can be presented in adults. Approximately 70% will come out from the cerebellar vermis. 20% will have tumor dissemination at diagnosis. It can be sporadic, but we all know the risk factors related to cancer predisposition syndromes. And some of the germline mutations that we have is the Wnt signaling pathway would occur in the Turco syndrome, the Li-Fraumeni syndrome, in which we have the mutated on TP53. So one of the risk factors, well-known risk factors, are these cancer predisposition syndromes. Histopathology of the medulloblastomas, we have the classic form, often related to non-Wnt and non-sonic hedgehog subgroups, often arising from the midline. And then we have the desmoplastic and extensive nodularity, often related to sonic hedgehog activated. Anaplastic is often, it can be in all of them, but it is often related to activated sonic hedgehog. Has a lot of mitosis, often related to a bad prognosis. Extensive nodularity, often related with good prognosis in infant. So from the work of Dr. Taylor in 2012, we came out to know that there's a consensus of 4 subgroups for different entities: the winged subtype, sonic hedgehog subtype, group 3, and group 4. So the winged subtype, approximately 10% of the cases, kids above the age of 4 and adolescents have a great prognosis, often present a CT and NB1 mutation in a genetic with monosomy of chromosome 6. Then we have the sonic hedgehog, which is approximately 30% of the population, occurring both in infants, in adolescents, and adults. There is a mink with amplification and a recurrent in the TP53, which will actually be a great information for risk stratification and treatment. And then we have group 3. Unfortunately, that's the worst prognosis, often in infants. Most of the cases metastatic, at diagnosis, recurring. So it's unfortunately it's one of the worst prognosis, particularly because infants under the age of 3, we're unable to do radiation therapy. And then we have group 4, which is approximately between 35% to 40% of cases. And Professor Cavalli in 2017 then actually came with this great paper showing that not only we have 4 molecular subgroups of medulloblastomas, but actually a total of 12 subgroups. So the heterogeneity within these groups accounts for the previously unexplained variation. Although we have winged sonic hedgehog, those group 3 and group 4, which are not non-winged and non-sonic hedgehog, they are different entities with different prognosis and different response to treatment. So often kids will have a clinical presentation, most often with hydrocephalus, which will be intracranial hypertension syndrome. These kids will present with headaches, nausea, vomiting, blurred vision, double vision, sleepiness, confusion. In case of disseminated disease, they might even have numbness of the arms and legs. This is a 3-year-old male that we treated at our clinic. Brain CT is usually performed initially, and often we see a hyperdense posterior fossa mass implicating in obstruction of the CSF, and then we'll have the enlargement of the ventricles, supratentorial ventricles. On MRI, this is a T2 coronal. We can see iso-intense mass in the midline, posterior fossa. In a T2 flare, you often see a posterior fossa mass, iso to hyperintense, compressing the brainstem structures surrounding and the cerebellar surrounding. In a T1 GAD, we often see a heterogeneous posterior fossa mass compressing the adjacent structure. In treatment, just as Dr. Moni just mentioned, treatment, it's mainly a multimodal treatment. It consists of surgery, a maximal safe surgical resection. That's why in our practice, we have intraoperative monitoring for all the patients. Ideally, have CSF cytology, because once we have a craniospine MRI, although negative, but if we have a CSF cytology positive, that will consist with disseminated disease, and that's a change of a treatment in prognosis. And then we have radiotherapy. Unfortunately, in Brazil, we do not have proton beam although we know that some of the Latin American countries, if I'm not mistaken, Chile and Argentina, these countries have proton beam. We do a radiation therapy, the traditional, and then chemotherapy with some current agents. So although this treatment implemented, a 5-year prognosis is around 72%. Of course, that will depend according age, tumor grade, and tumor type, molecular subgroups, and traits of cancer. So this is a little review about medulloblastoma. And now we're going to be talking about the Brazilian protocol. This is our hospital. Santa Marcelina Hospital is a public and private hospital in the periphery of São Paulo. It is responsible to attend approximately 5 million people from this population. And this is TUCA. TUCA is a nonprofit cancer organization that assists us with the financial aids to give the best to treat oncology patient and oncology pediatric patient. So our protocol was based on treating medulloblastomas according to the molecular subgroups. Just a parenthesis here. We know the standard methods of diagnosis medulloblastoma subgroups is very expensive. So the idea of this protocol that was developed was to diagnose medulloblastomas and classified in different subgroups using techniques that was not only effective but also cost effective. The principal investigator is Dr. Sidney Appelman. He's the chairman of the Brain Tumor Cooperative Group of the Brazilian Pediatric Oncology Society and the chief of Pediatric Oncology Department of Santa Marcelina Hospital. He's the key person that runs the oncology pediatric center in our hospital. And we have the opportunity to have a discussion at least a month with Dr. Roger Parker, and we go over all the cases with Roger Parker, and he actually helped us to decide the best treatment according to the disease. So the rationale for this project is that medulloblastoma subgroups are different biological entities in demographics, histology, genetics, and clinical outcomes. So the idea here was to classify the molecular subgroups and to promote uniform treatment of medulloblastoma patients in Latin American countries. The primary objective of this project was to evaluate the therapeutical response and survival rates of medulloblastoma patients treated according to the molecular subgroups. And secondary objective was to evaluate the efficiency and effectiveness of medulloblastoma subgroups classification based on combined analysis, immunohistochemistry profile, gene expression, and FISH analysis. So the current protocol was based on this pilot study that I'm about to present here, which was a prospective study. Total of 54 samples were obtained, patients between the ages of 4 and 19 years old. And the samples were either paraffin samples or tumor samples obtained within 40 days of surgery. Exclusion criteria were previous treatment implemented, or tumor samples obtained over 40 days of surgery, or poor quality samples. So this is how we did the study for tumor grading for subgroup classification. So we would take the 54 from this pilot study, 54 samples. We would run immunohistochemistry to classify into Wnt sonic hedgehog and non-Wnt and non-sonic hedgehog group. We would do the immunohistochemistry for beta-catenin, filament A, GAP1, YAP1. and then we run the risk stratification to find out P53. Then we would do the real-time PCR, approximately 17 genes, and that would enable us to classify it into Wnt, sonic hedgehog, group 3, and group 4. And then we would go to FISH to confirm Wnt for monosomy of chromosome 6 and do the risk stratification for the amplification of MYC. So that was how this is the drawing of the pilot study that we did, and then developed the protocol for the Brazilian protocol for medulloblastoma. So again, this is the immunohistochemistry. So Wnt classification, subgroup classification would have a nuclear beta-catenin positive, GAB1 negative, YAP1 positive, and filament A positive or negative. Sonic hedgehog would have negative for beta-catenin, GAB1, YAP1, and filament A would be positive. If for the non-Wnt and non-sonic hedgehog subgroup would have negative beta-catenin, YAP1, and filament 1 negative, GAB1 either positive or negative. This is for the real-time PCR classification that we use to separate into group 3 and group 4. And the FISH study was used for the detection, amplification of c-MYC and N-MYC, and for the monosomy of chromosome 6 that is observed in the Wnt subgroup. So again, this is how we did. I'm just go over how we did for each subgroup and how we classify it. So we have a Wnt immunophenotype. We would run a real-time PCR, would go into the Wnt pathway activation. If yes, we would separate into Wnt subgroup. If no, we do the FISH with the study of monosomy of chromosome 6. For the sonic hedgehog subgroup, we would do the same thing. So we would have the immunophenotype for sonic hedgehog. We would run a real-time PCR, and that would separate into Wnt or sonic hedgehog activation. And for the activation of sonic hedgehog, we'd run the P53 for a mutation in wild type that would give us the risk stratification for the sonic hedgehog. Group 3 and group 4, we would, for those samples that would be non-Wnt and non-sonic hedgehog immune phenotype, we'd run the real-time PCR. That would separate, that would classify into group 3 activation genes and group 4. And this is how we drew our pilot study in order to find the subgroups in a cost-effective ways. So this was the subgroup classification. This is what we came out. The classic, the Wnt, often histology was classic, GAB1, YAP1 positive, GAB1 negative, and the monosomy of chromosome 6. When we run FISH analysis, sonic hedgehog, we would find out the P53 status for risk stratification, group 3 and group 4, and the amplification of MYC and N-MYC. So in total, this is our result. We have 54 formalin fixed paraffin and Baptist samples. 98% we could separate in Wnt, sonic hedgehog, or non-Wnt or non-sonic hedgehog just by doing a immunohistochemistry study. And when we added the real-time PCR and FISH, we could separate into Wnt, sonic hedgehog, group 3 and group 5 in almost 82% of the cases. And for risk stratification, which will assist us posteriorly on treatment implementation, would classify in low risk, intermediate, and high risk. For low risk patients, we will have local disease, that is no disseminated disease with residual tumor or less 1.5 cubic centimeters, and Wnt subgroup that we know that has a good prognosis. Intermediate risk would have also local disease with a residual tumor less than 1.5 cubic centimeter and has the histopathology of classic, desmoplasty, or extensive nodularity. For high-risk patients, we would have disseminated disease at diagnosis or residual tumor above 1.5 cubic centimeters, or anaplastic or large cells in histopathology, and also had the sonic hedgehog TP53 mutator or CMYC amplification on fish analysis. So based on our results from that pilot study, we observed that an estimated 3-year overall survival, according to the risk stratification that we previously defined, low risk, 100% of the patients in 3 years were still alive, average risk 60%, in high risk patients, according to the Kaplan-Meier survival curve, were alive in 3 years as overall survival. So we compared this with the work of Cower. Most of what we did, we based on this previously work in comparing to our data and their data. We had the classification of all 4 molecular subgroups with about 81%. According to them, they had 86%. And the remaining non-winter non-sonic hedgehog, approximately 20%, and they had 13%. And we observed that remaining non-winter non-sonic hedgehog medulloblastomas subgroups could not be separated because of poor quality material in RNA. And then we compared our results with some of the Brazilian cohort of patients in the literature, and we could definitely classify in sonic hedgehog, wind subgroup, group 3 and group 4 in a very effective way, very similar to literature. So today, for that pilot project, we initially we had Brazil and 3 other South American countries. Now it's a bigger project in how we develop our Brazilian protocol for treatment of medulloblastomas. We have not only South American, but also North America, Central America joining us for this great project. So the pilot study resulted us that we can actually classify medulloblastoma into subgroups using immunohistochemistry, real-time PCR in fish. It works up very well with formalin-fixed tissue. It enables us to classify all molecular subgroups in most of the cases. It's a reliable method, and definitely is very cost-effective, with an estimated price of $220 per patient. Although for us, we do not charge all the centers that would send us the samples. There is no charge for that, but it's definitely a low cost to classify those subgroups. So in conclusion, the project definitely gives accessibility to accurate diagnosis. It promotes a stratification adjuvant treatment based on molecular subgroups. Definitely is a treatment protocol, subgroup specific, which enable us to improve prognosis and treatment for all these kids and reduce treatment-related mobility. So with that, I end this presentation. It's a great honor to inform what we've been doing in our country. We definitely have limited resources, but we try to treat patients according to what is the standard in most of the developed countries, with subgroup stratification, and implement the best treatment that we can in our country. Thank you.
Thank you, Professor. Professor Benifla.
For this interesting lecture. And I would like to congratulate you for this study that you are going to do. I would be happy if I would be able to be part of your recruitment protocol. Unfortunately, it seems that we are too far. I think that this type of adjusted protocol is the future of the medulloblastoma treatment. And this is the first and probably very, very important step towards adjusting and personalize the treatment of children with medulloblastoma. Do you have a recruitment protocol? Did you publish it?
We're on the basis of publish. We published the pilot study, but this bigger one that became the Brazilian protocol is underway, because now we have more centers joining the protocol. But I'll send it to you.
Yes, great. Thank you so much.
Sure.
Thank you so much.
Sure.
In the previous webinar that we spoke about medulloblastoma in this forum, I was against the 1.5 centimeter limit of resection of medulloblastoma, and I think that near total resection is as good as gross total resection, and maybe to save the children. And they said, when we know the subgroup, we may know that maybe we want to go back and resect the rest of the tumor,
right,
or we can treat him, so I would be very happy to if you can send it to me. Thank you so much.
Sure. Thank you.
Thank you, Professor Benifla. I have a few questions for you, Professor Redha. My first question, Professor, based on your study with the stratification of the prognosis, because we do have a patient who required resurgery, and sometimes at the same location or sometimes at a different location cranially, even some actually extended up to supratentorial in recurrent cases. So do you advocate case that with high risk, no resurgery? Do you have such protocol? My second question, Professor, is there a need to have a cranial spinal imaging before surgery in your protocol? And my last question, Professor, in your study, based on the histologic part, do you have any form of comparison with the tumor marker in the CSF during a CSF diversion procedure or imaging that can help us in the risk stratification before surgery? Thank you, Professor.
Thank you very much, Liu. Could you repeat your last question for me, please?
Yeah, means that usually from histology, we do need to undergo surgery debulking. So do you have any study to show that any correlation between your result and also with the imaging or CSF marker that you mentioned that would give us some clue before we actually go in and do the surgery? Would that make a difference in terms of extent of surgery that's going to be provided for the patient?
Okay, thank you very much. So for the first question, of course, what is preconized, what is the standard today is to do a maximal safe surgical resection, because the disease itself is very malignant. So it doesn't make a real sense to give more morbidity to a kid because the disease itself is very morbid. We did not have any case that we did no surgery. So most of the case we try to do, we have intraoperative monitoring, and we do a maximal safe surgical resection. And just as Dr. Moni mentioned, with the subgroups now, in a way, would actually facilitate for us in case we leave some tumor, if we do need to do a second surgery according to the molecular subgroups. But I agree with him. I always think of near total resection or gross total resection, that would be the best. But subgroups will tell us different now. But definitely morbidity, the disease itself is very morbid. It doesn't make any sense to do an aggressive procedure and have a lot of morbidity, and the kids can even go to further treatment. We do actually in our protocol, we try to do a craniospinal MRI before surgery. always we try to do that. But Dr. Roger Parker, every medulloblastoma case we try to discuss with him. He always asks, although we did prior surgery, a craniospinal MRI, before we initiate radiation therapy, we have another craniospinal surgery, craniospinal imaging before we start treatment. And we do also do a CSF analysis, because although if imaging doesn't show any dissemination, if we do have a positive CSF analysis, we have to consider it as disseminated disease. And for your last question, we do not have any study. The study that we have now is this pilot study. In imaging, definitely help us to decide what is the way to treat, if disseminated or not. Although for kids under the age of 3, even if you have a disseminated disease, it's much harder to treat because of the radiation. We do not have proton beam here in Brazil, although some of the centers in Latin Americans have, but we do not. So, but definitely under the age of 3, it's very challenging to treat medulloblastoma patients.
Thank you very much.
If I may comment about the pre-surgical MRI studies, it is routine nowadays to do neuroaxis MRI, because if there is dissemination, there is no point in struggling with the tumor. And as I mentioned before, the complications of gross total resection could be devastating, especially the cerebellar mutism. So if there is dissemination, you just do decompression and that's it. If you need to do decompression, otherwise there is no point. There is no change in the prognosis.
I agree.
Yeah, thank you both, Professor. I couldn't see any question in the chat box, so we may conclude today's session. May we hear a concluding remark from Professor Benifla, Professor?
Thank you again for this lecture. Thank you for inviting us to this important webinar. Unfortunately, there are no many participants in this webinar, but hopefully next time we'll be able to have more. I think that we can do all around the world some group discussions, not only with group discussions of pediatric neurosurgery, trauma, etc. It is better than flying. Well, I love to fly, but if we can discuss it over the Atlantic Ocean with Brazil, it's better than flying only for one discussion. Thank you again for this important webinar. Thank you for the trauma lecture. That was very, very good. Yeah.
Thank you, Professor. Just for your information, Professor, we do have also broadcasting in the YouTube channel and also WeChat channel. Usually we have about more than 500 people, which are not reflected in this webinar. And we also have, we're going to upload this in our YouTube channel, and we do get people who watch our webinar. And thank you very much for your participation, Professor. And on behalf of the Education Committee of the ACNS and President Professor Yoko Kato, I would like to thank both speakers for today, Professor Angelos Kolias and Professor Roberto and Professor Roberta Reha, and also the chair, Professor Andres Rubiano and Professor Molly Benifla, for the time and support for this webinar. I would like also express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. Thank you for joining.